This afternoon, we've got some extremely distinguished people giving evidence to us. We'll be hearing from Professor Michael Marmot, Joe Bibby, the Director of Health at the Health Foundation. We'll also hear after them from Michael Wood from the NHS Confederation. We've got James Bullion, President of ADASS, and also, I must say, Director of Adult Social Services in my own county of Norfolk. We've got Imelda Redmond from HealthWatch, and we've got Bill McCarthy, the NW Director at NHS England. So a fantastic afternoon ahead of us. You'll be conscious, all of you, that there was we published a position statement on the government's white paper, which we called a glass half full. And we gave a welcome to the white paper as a positive foundation upon which to build strong and accountable place-based partnerships focused on improved health and well-being outcomes. But there are issues. It raises questions, the position paper, 6 questions relating to the purpose of integrated care systems. And then there's another 6 questions regarding where power will lie in the new system. Those latter 6 questions will be dealt with at a second session that will be taking place on the 21st of May, which will be chaired by my co-chair, Andy Burnham. But today we focus on purpose. Can I just mention to those of you who are attending but who are not commissioners, you're very welcome. Please put questions if you have any in the chat function, and we will pick them all up. We won't have time to bring you all in to ask questions individually because we've got a very tight agenda, but we welcome your contributions and your thoughts. Can I also tell you all that the session is being recorded? If you have an issue with that, then it would be better for you if you're observing and you're not happy with it in any way, then to leave, but I don't think it should affect you. We may slightly overrun beyond the advertised end time of 5 p.m, but I'm very keen to stick strictly to time and for all contributors to be quite disciplined in sticking to time if that's possible. So the findings from this session and the other roundtable on the 21st of May will be written up by the Secretariat into a short report, and we very much hope that that informs debate at second reading and the committee stage of the forthcoming bill. Can I also just remind commissioners, speakers and other attendees that the idea is that at the end of the session, we're all clear about the changes we want to see included in any bill that's published after the Queen's speech. And if those witnesses giving evidence could focus particularly on what changes you think may be needed to the bill when it is published in order to maximise the opportunity that we have in front of us. So I think those are the key things that I wanted to mention. In our first session, we have evidence from Professor Michael Marmot and from Joe Bibby. Each of you has 7.5 minutes. I'll then afterwards bring in Michael Wood briefly, and then there will be questions and contributions from commissioners. So can I offer a really warm welcome to Professor Michael Marmot, first of all. Very good to have you back, Michael. We can't hear you. Are you muted,
Yeah,
Michael?
Sorry, I clicked on unmute 4 times, but it worked the 4th time. So,
excellent.
Yeah, so what I said was thank you very much. It's a pleasure to be back. You didn't ask specifically the question on devolution. I think when we met last time, I said that from my point of view, there was a positive and a negative reason for thinking that the right locus of action was regionally or locally. The negative reason was if national government wasn't going to take action to reduce health inequalities, it had to be done at some other level. And city, regional, local level would be the right place. So that's a negative reason. The positive reason is much can be done at regional, city, local level, and the close connection, the potentially closer connection between people operating at that level and the population they serve is a positive asset. So for both those reasons, both the negative and the positive, in my experience, it's good to have the local level involved. And you asked me to talk about health inequalities. The thrust of the various reports that I've done, and particularly the 2010 report, the Marmot Review, Fair Society, Healthy Lives, in the wake of the WHO Global Commission on Social Determinants of Health that I chaired, the thrust of those reports is that most of the determinants of health inequalities lie outside the healthcare system. And whereas those of us concerned with health tend by default to be concerned with the healthcare system, the key determinants lie outside the healthcare system. So then the big question is, can integrated care systems provide a vehicle, an opportunity to work on the social determinants of health? Because otherwise they'll continue to do important work, but it'll be at the margin of what's needed to make a difference on health inequalities. The second thing I want to say is the two reports that we produced in 2020 together with the Health Foundation. Joe Bibby is here. The first one documented that things were going in the wrong direction. Over the decade from 2010, life expectancy more or less stopped improving, health inequalities increased, and life expectancy for the poorest people outside London went down. And this is really shocking. Really shocking. It's almost unparalleled in peacetime to have such a thing happen. Health for the poorest people in our society got worse, and health stopped improving. And that wasn't a failure of the healthcare system. That was related to the key social determinants of health. Now, if an integrated care system is supposed to be improving health and reducing inequalities in health for the population that it serves, it cannot do this without working together with others that are addressing the social determinants of health. In our second report, Build Back Fairer, we chose that title advisedly. My general assumption, informed by my global work on the WHO Commission on Social Determinants of Health, we did a commission in the European region, we did one in the Americas, and on the 31st of March, we published the report of the commission that I chaired on social determinants of health in the Eastern Mediterranean region of WHO. And we gave that report the title, Build Back Fairer. And my general assumption based on all of that is that the health of the population tells us something fundamental about how well the society is doing in meeting the needs of its citizens. And health inequalities tells us something very important about inequalities in society. And in the decade from 2010 to 2020, our society failed to improve and inequalities in our society got bigger. So that's the big challenge. And then in our Build Back Fairer report, we demonstrated, as others have done, that the pandemic and the societal response to the pandemic made inequalities worse. And therefore, we should see integrated care systems developing as part of what I would hope would be a national conversation on what kind of society we want. We do not, I would hope, want to go back to the status quo before the pandemic crashed upon us, because, as our February 2020 report made clear, the status quo was far from desirable. Health had stopped improving, inequalities in health were getting bigger, and health for the poorest people was getting worse. That was not desirable. So this ought to be part of a societal conversation of what kind of society do we want. An integrated care system that's working in areas of the Northeast and the Northwest. And earlier this afternoon, we had a conversation with our Greater Manchester Marmot steering group. We're working with Greater Manchester, as Andy Burnham will tell you, with not just the health and social care system, but the whole of Greater Manchester, on what can be done to build back fairer, to produce fairer society. And just to finish, we said there was a great deal that a healthcare system can do to address social determinants of health. First, education and training. Second, seeing the patient in a broader perspective. Third, when we produced a report on this, we were thinking about employees in the healthcare system, but I would broaden that to say thinking about anchor institutions and the broader impact of the healthcare system, not just on its employees, but on the communities in which it operates, and environmental impact. Fourth, working in partnership. And fifth, advocacy. So I think these are all key roles for healthcare system in addressing the social determinants of health to produce greater health equity.
Michael, you've set the standard, brilliant evidence, and you kept to time. So thank you very much indeed. And can I now bring in Joe Bibby? Welcome to you as well from the Health Foundation. Joe.
Great. Hopefully you can hear me now.
We can hear you, yeah.
Right. Okay, well, thanks for a chance to contribute to this commission. Looking at the commentary on the white paper, there does seem to be general consensus on the need to strengthen the focus on health and economic well-being, and particularly have that emphasis on inequalities. And the white paper talks about the triple aim, which is a good starting point. But we would say that the focus on inequalities needs to be more explicit. So in thinking about this, I was going to share some reflections on what ICSs can do themselves when they're thinking about health inequalities, but also the context they operate in. So thinking about ICSs, I think the really important thing is going to be to ensure that there's a population need approach to services. So rather than the kind of individual demand led approach that we often see with it's who turns up gets the care, or it's a provider supply led approach. What we need is something that really is led by the need of a population. And to do this is going to require capacity and capability for population health management to be embedded across all providers. We know that too often people have the poorest people have late stage diagnoses, and as a consequence, they have worse outcomes from care. And so it's so important that providers understand the populations they serve and ensure that the right people are coming through the doors. And when I was looking at who was on the commission, I kind of thought, well, I won't be the only person who remembers the sort of strapline, right care, right time, right place. Which, sort of stands true, but I think we need to add right people. We need to have the right people getting the right care at the right time in the right place. And this is also going to need more data sharing between organisations so that they can use population health management tools to identify those high-risk groups. But beyond that, it's also going to be necessary to take into account people's own circumstances, their working conditions, their living conditions, and what that means for them accessing services and self-managing. And without an explicit attention being paid to people's circumstances, there is a risk that good care provision widens inequalities because it works for some people but not for others. So this is a sort of another area to consider. We've got to make sure that ICSs are judged against the extent to which they're taking preventative action. For instance, what would be the never event that a prevention-led system should be aiming to eradicate? And what's the balance of spend that a prevention-led system would have between preventative care and acute care? Another area to consider is the investment in public mental health. We know that poor mental health results in poorer physical health, but the capacity in the system for that early intervention is currently insufficient and needs better investment and coordination. And then just to echo what Michael was saying, the NHS needs to think about its role as an anchor institution, who it employs, who's in the supply chain, how it uses premises and investments to promote local health and well-being. But I think there's another side to the NHS, which is its voice in the system and the role it can play in advocating for better housing policies, better quality work, green spaces, and so on. And I think one of the recent tools that's emerged in the last 6 months is the ONS Health Index, which looks at a range of metrics about performance in a place against different drivers of health, and that can help focus attention. But as I said, we've got to think about the NHS and ICSs working in a wider context. And as Michael said, all the evidence shows there's a limit to what the NHS can do alone. In fact, really a small part. But it does have a powerful voice. And I think it does need to be advocating for an effective strategy that takes a whole society approach to health inequalities. This will mean having an ambitious goal. It will mean having better cross-government coordination, perhaps led from the Cabinet Office or Treasury, and there needs to be some independent scrutiny so that Parliament gets independent commentary on what's happening to health in the population. One of the things the Health Foundation is doing at the moment, and we can share this with the Commission, is we're consulting on a working paper that sets out the components of what a cross-government strategy to address health inequalities would look like. On some of the other areas that you mentioned in the questions that you set out, I think clearly it's important that we see really good integration between NHS social care and public health, but we've got to remember the potential and the opportunity that public health offers in the way it can look out to local government, how it can get around the table on conversations about housing, planning, economic development, and so on. But it also needs its funding to be restored. It's nearly 20% less, the public health grant, than it was in 2015-16. And our calculations say it needs a minimum of £1 billion to restore it. So that's an important factor when we're thinking about the preventative role of ICSs. There's also the question about the relationship with social enterprise and voluntary and community sector. Clearly, this is critical. ICSs, if they're going to understand and address local social needs, have to have good relationships and deep reach into the voluntary and community sector. I was struck by a proposal that National Voices have made about ICSs being obliged to interrogate and report on the health and nature of the voluntary and community sector locally, so that they pay attention to it and they look at the financial and organisational resilience. I think the other thing that we know is that for some of the small but vital charities, it's very hard for them to participate through some of the contracting arrangements that happen in the NHS. So ICSs need to make sure they remove those barriers. On digital innovation, I mean, that's something we've obviously just seen overnight with the pandemic, huge changes, but we need to make sure they don't widen inequalities. And I would refer the Commission to the work that the Good Things Foundation are doing on digital inclusivity. And then finally, you asked about the, well, two things. You asked about the whether there should be the same statutory role for mayors in the devolved areas besides London to take a role in health, and I think absolutely. We know that health has to be viewed locally. And the final point was around co-production. And I think the one thing I'd say on co-production, we know it's important. We've been saying it for decades. I don't think it's a lack of knowledge. I think it's about a mindset shift. And let's hope that ICSs can really lead that shift in moving to more co-production. So thank you, and happy to take questions.
Joe, thank you so much. That was great. Thanks also to Daniel and Nathan, who've been contributing comments in the chat function. Just encourage anyone who's listening to the witnesses, if you want to give your reflections on what's being said, then please do so. It can all be taken into account at the end of the session. Can I now bring in Michael Wood briefly, Michael, to add your reflections from the NHS Confederation? Michael.
Thanks, Norman. Two really strong, evidence is there from Professor Marmot and Joy. And I just wanted to ask a question, actually, Norman, if it's okay, and start the ball rolling on questions. And I just wanted to, just building on what Professor Marmot and Joe have said, reflect back on the original consultation last November on integrated care, which had as one of its 4 key purposes for systems, helping the NHS to support that broader social and economic development. Now, that was very welcome, hugely supportive, yet perhaps that's the least well defined of all those purposes. Perhaps that's more implicit than explicit in the white paper. Now, I'm hopeful that the Commission can play a part in, I guess, leading on this policy as we do look to put some detail down. But I'm curious as to how we can do that, and how we can ensure that this priority is not forgotten in the rush to the detail and the governance of ICSs as they develop. So that's my question, Norman, just back to Joe and to Professor Marmot, and to kick off the wider question session.
Brilliant, Michael. So who wants to come in first in response to that? Joe, do you have any thoughts in response to Michael's question? You're muted, Joe.
Well, I would be quite interested in Michael's thoughts, because I know he's thought about this a lot, but I think certainly, there is an opportunity for there to be much more attention paid to how the economic muscle of the NHS can be to the benefit of local communities, whether that's through who's being employed. I mean, I was struck, in areas where there is sort of very high numbers of families in poverty, but in work, and that's reflecting that there are obviously kind of poor labour markets in those areas. So really, the NHS could be thinking about how is it actually targeting recruitment into those sections of the population and offering better quality work, better quality jobs. So I think there's a lot that can be done in this space. I think the sort of physical assets that the NHS has and how they're used to create opportunities for whether it's voluntary and community sector or others to use those resources is important. And the Health Foundation is supporting a Anchors Learning Network, which is, in kind of real time exploring this with a group of NHS providers.
Thank you. Michael?
Well, in general, I don't support the great woman/man view of history, but it is key to have charismatic individuals. In our experience, working with Coventry, it took the chief executive of the local council and the leader of the council, working with Greater Manchester. It took the mayor and the Director of Health and Social Care Partnership together to say, we want to do this in Greater Manchester. So it took charismatic informed individuals, and it's very helpful, and it relates to one of your questions, to get the mayor or the leader of the local government involved and leading. Is vital to get the Health and Social Care Partnership involved as well. But by getting the mayor, I said this afternoon, we had a meeting of the Marmot Steering Group in Greater Manchester. One of the key players is Joanne Roney, who's the chief executive of Manchester City Council. So we've got the chief executive of the largest city in GM as part of this steering group, as well as public health and health and social care. So it really takes commitment from, I don't know if the centre is the right word, but you know what I mean. I don't mean the centre in London. I mean the centre in the city government, because that way you get the other parts involved. And then you've got the Health and Social Care Partnership thinking about education. I mean, one of the things we talked about is well-being of school children. Now, you might say, what's the health and social care system got to do with that? Well, mental health, perhaps. It's absolutely vital. So we're talking about well-being of school children. We're talking about housing. We are addressing, forgive me for raising this question, questions of structural racism that have to be addressed. And that leadership has to come from the city leadership as well as the leadership of health and social care.
Thank you very much. Now, I'm opening this up to other commissioners to ask any questions you want. We've got about 10 minutes left before we have to start the next evidence session. So succinct questions, Paulette and then Alistair.
My question, good afternoon and thank you. My question is really succinct. It was highlighted by one of the speakers that they supported the mayoral position as the person that leads within health on the local basis. Could I ask for a bit of explanation? Because as the LGA, we don't actually support that position because we believe if it's place-based, it shouldn't be at the combined mayoral level. So I'd just like a bit more clarity as to why that position was supported. Thank you.
Joe, I think that was you that made that comment, so over to you.
Yeah, sure. So just to say on that, I think perhaps in the race to keep within 7.5 minutes, maybe I wasn't entirely clear. I understood the question to be, should the mayor have responsibilities around health in the way that the London mayor does? But that to me isn't the same as them being the sole accountable leader. So clearly there are, you know, within councils and the NHS structures, the leaders locally for health, but should there be some more explicit consideration being given by city region mayors of what they can be doing and the assets at their resource, at their disposal? That was what the reference was towards. So not instead as, but kind of as well as.
Thank you, Joe. So I'm going to go to Alistair next. Over to you, Alistair.
Thanks, Norman, very much, and many thanks, colleagues, for the two presentations. My question was this: knowing both local authorities and NHS administration as you do, and seeing the creative tension that is built into the ICS structure, do you think the parliamentary process that will work this legislation through, should it be more directive of the responsibilities of the ICSs in respect of both the NHS or local government, or should it leave room for local ambiguity and local discretion? Because of course that may mean that different priorities come up in different areas, which may be the best thing. And as I say, knowing how local government and NHS works, and knowing the influence of strong-minded individuals in different places, do you want to see legislation more directive about what ICSs should do in terms of public health, or are you content to leave it to the creative tension that ICSs imply?
So who wants to respond to that? Michael or Joe? Michael.
I'll respond by saying I don't know the answer to that question. It's a good question, but a bit like Paulette's question, these machinery of government questions are not good on. What I would like to see is that health inequalities has central place. Because once you do that, that reduction of health inequalities, once you do that, it means that the integrated care system has to work with local government and with other players because you can't reduce health inequalities otherwise. Whether it should be in the legislation to have them working together or not, I'm not sure what the best way is to do it. But to have reduction of health inequalities as a major aim requires them to work across sectors. You can't do it any other way.
And I see you're nodding at that, Joe. Any additional comments from you?
Yeah, I mean, I think just, we've got to focus on the outcomes we want to achieve. And if we're holding people to account to the outcomes, that will incentivise the right ways of working in such a way to allow for local sort of flexibility and priorities.
And Joe, I think a comment on this was made in the chat function that presumably the outcomes that we're after should relate to population health, not strictly to narrow health outcomes. Is that right?
Yeah, I mean, I'm not quite sure what the distinction being made in the chat is, but I think, we know that within places there can be differences in life expectancy of 10 years or healthy life expectancy of more. It's about closing that gap and looking at the whole breadth of actions that are needed to be taken.
Yeah. And Michael, I think you indicated your agreement to that as well. Now, we've got two people with hands up. I want to bring you both in, but it needs to be succinct on the questions and the answers. So Joe, first of all.
Thank you very much, Professor Marmot and Joe. Nice to see you again, Joe. My question is really around the added social value. Obviously, I'm interested representing social enterprises, but also the diverse range of providers. And there is a risk through these proposals that we will lose some of that diversity. And yet these are the very organisations who are looking at added social value, which is baked into their fundamental purpose, and who automatically work with a wider group of partners and operate with those whose needs are not being met. So my question is, how do we ensure that these proposals inadvertently, not necessarily completely intended, will actually end up with the loss of that diversity of provision and that wider ability to include partners and reach more widely than some of the NHS providers will be able to do in the future?
Now I'm going to bring in Seamus as well, and then Joe and Michael can respond to whatever you want to respond to for the last two contributors. Seamus, succinct, please.
Thank you, Norman. So my comments to do with quite a bit of discussion so far about, and quite rightly so, about the inequalities within ICSs that need to be addressed at local levels. But the inequalities between ICSs, these are populations of 3 to 5 million people sometimes, and the difference between the health inequalities in the north and the south is stark and getting starker, as Michael has said. So that's the first thing that needs to be hardwired into the legislation, one would have thought, but there's very little evidence of it being so. The second one is the role that innovation should play in ICSs, both to improve systems. Innovation and quality improvement drive both improvement in healthcare systems. They also drive economic growth, which is the major extrinsic factor in the changing the health of the population, better jobs. So those two can be hardwired into legislation. Great.
Thank you. So Michael, first, do you want to respond to either of those?
I'd like to respond to both of them, if
Good.
I may, and I'll try and be brief. Firstly, Joe Pritchard's question about social value and social enterprises. I've been saying for about 15 years that people like me are making a mistake because we don't deal with the private sector. which is vitally important. So it's not just social enterprises, but the private sector. So I've been saying this, beating myself up. And a large corporation approached me quite recently and watch this space. We're hoping to launch a partnership within the next month and a half, saying, what can we do as a private sector, as a corporation, that would improve health and well-being in the areas in which we operate? Wow, that's very important.
positive.
That's very important, you know, because to say, well, this is just for national government or local government and maybe the voluntary and community sector, yeah, they're vitally important. But what about the private sector that employs people that could function as an anchor institution? And then the particular corporation that we've been talking to said, we've got great convening power. How would you feel if we brought some other corporations into the discussion? And it doesn't happen often, but he said, why aren't you saying anything? I said, because I'm thinking. Doesn't happen often, but then he said, we really want to. So let's see what happens. It's not just social enterprise, but enterprise should be part of this, creating social and economic viability, which relates to Seamus O'Neill's question that if you're living in the northeast and the northwest and you're in the most deprived decile and your health is getting worse, you can have the best ICS in the world, but that by itself isn't going to do it. The question is your region going to be economically viable? And what are the social and economic conditions for this and the next generation going to be like? And that's absolutely vital. And if I may, in my 2010 report, I coined the rather awkward phrase, proportionate universalism. We want universalist policies with effort proportionate to need. And what happened over the decade from 2010 was we had effort inversely proportionate to need. The more deprived the area, the greater the cuts in funding. It was almost as if it was designed to increase these inequalities between regions. Well, we know what the evidence shows. That needs to be reversed. Now, behind your question, there's only so much the ICS by itself can do. That takes a funding settlement from the centre that reverses the regressive nature of those cuts. And that's vital.
Thank you, Michael. Jo, some closing remarks?
Sure. Okay. Well, thank you on those points. I mean, I think absolutely share the sort of concern about the risk of losing the sort of diversity and richness that exists in the voluntary and community sector. And obviously, for all the reasons you said, it's vital that we don't. I'm not an expert on legislation, but my observation would be that generally, I don't think it's legislation that gets in the way. You know, we know there are things like the Social Value Act that get interpreted in vastly different ways at local level, some to really great effect, and others it's just not used at all. And I think I'd kind of go back to my early comment that a lot of these things come down to the mindsets and the leadership and the sort of understanding. And so again, we need to have those kind of outcome measures in place so that ICSs are held to account for what matters, and hopefully the rest will follow. And on the inequality between ICS's point, totally agree. And this is why this has to sit in the context of a sort of whole society and whole government approach to addressing inequalities that look at those regional variations as well.
Well, thank you so much, Jo and Michael. Really valuable to have your evidence this afternoon, and very much appreciated. You're welcome to stay on and listen if you're able to. If you're not able to, thank you, and we will no doubt be in touch with you with the conclusions that we reach. But thank you so much. Can I now welcome James Bullion, President of ADASS, and Imelda Redmond, Chief Executive of HealthWatch. James first, and the plea again, 7.5 minutes each, if that's possible, so that we have enough time for questions. James, first of all.
Well, thank you very much, colleagues. And so I'm James Bullion, President of ADASS. And we produced a vision last year for social care reform. At the heart of that was a statement around better integrated care. But our integration and our definition of social care is quite wide. So we would think of health, housing, care, employment, technology and relationships as being a really crucial part of the ambition. For us, in bringing local authorities and social care specifically into this picture, for us, the way we work in place is crucially important. So the first point I would make is that there needs to be a firmer expectation of alignment, actually, between the systems at local and regional level. And these tectonic plates only shift once in a generation between health and local government. So Secretary of State, and I understand we'll be taking decisions this summer about better alignment between systems, but it seems to us that we must not miss the opportunity this time because in better alignment, we get better risk pooling locally of changes. The second issue I would raise is the role of local authorities, their health and wellbeing boards, their strategic approach to needs assessment and public health. And there isn't a clear explanation for how the ICS bodies within the NHS body within an ICS and the health and care partnership within an ICS could work together in local government. There is, of course, a need to keep flexibility because areas are different. Urban areas and rural areas, for example, might have a different set of arrangements in place. But the expectation that we will take the opportunity to take away the duplication and to really take advantage of the local government willingness to bring together partnerships as a single partnership ought to be taken in this legislation. And in particular, the infrastructure for children's services and this bill do not have a very good fit. They are not very well considered in both the legislation and in the proposals going forwards, and in our view need a further look on behalf of my colleagues from children's services. So this principle of subsidiarity and localism is really important to us, but we recognise in these structures a willingness to continue the NHS approach of a more place-based, bottom-up way of working. And we really would see the need for NHS bodies to really anchor themselves in this community way of working and to see the resources they bring to those community conversations as being important. One of our fears, I suppose, in this legislation is the NHS is under strain to get itself into a greater degree of treatment efficiency, whereas we see the opportunity here for more of a community-based approach to the wider determinants of health. The bill will bring together, and the ICSs will bring together some of the dividends of COVID, so the discharge to assess arrangements are a real positive. But in our view, the elements of health and care reform are now scattered between ICSs, between the social care future reform, between housing reform, which is not in either of the two systems. And there is a real need to use the ICS as a way of bringing together the 4 or 5 elements of reform that are now underway, including discharge to assess, the Mental Health Act, the Building the Right Support changes for learning disabilities, the liberty protection safeguards, and the assurance system for social care. And of course, we hope social care reform. And I really would be remiss of me, I'll be sacked as president for not saying that really the Secretary of State ought to be outlining reform at the same time in the same Queen's speech. And really, if ICSs are to have this mandated ability to deal with inequalities, it will need to be necessary for that anchored approach to take into account the wider groups that we work with in social care, which includes homelessness and rough sleeping, and includes refugee and asylum seekers and prisoners or people in the criminal justice system. And then two final points. The workforce issues in social care are well known. We have a 40% turnover and a 10% vacancy rate of 120,000 vacancies, and no real training plans and no real occupational health plans. And we might envisage this legislation having a requirement for the Secretary of State to have a plan for the NHS workforce, perhaps working with Health Education England. We think there's an opportunity here to have a plan with social care, either a parallel plan on the same timescale, or perhaps having a single plan. And there really is no reason to wait for that in social care reform terms. It's an urgent priority. And then finally, the ways of working in an area. The COVID year has demonstrated to us that we can take a group of names of people at risk in an area and intervene with them. And in my area, that started off as about 15,000 names. And in the end, it was 67,000 people who were at risk in my home county of Norfolk. Health and care coming together to intervene and protect and to do some prevention work. So it shows you the power of what ICSs can do if they are mandated to do that task. Thank you.
James, thank you very much for that evidence, and thank you for being so disciplined on time. Really appreciated. And can we now bring in Imelda Redmond? Imelda,
hi.
Welcome.
Thank you, and thank you so much for inviting me in today. There's three areas I'm going to cover quickly. One is around the ICS support for the development of social enterprise and voluntary organisations. I'll also look briefly at the role around stronger patient voice and co-production, and then finally I'll just do a few things about what I think needs to be strengthened as the bill goes through from the white paper. So I suppose the first thing for me to think about is why are we having this legislation? And the reason we're having this legislation is that there was quite a big ambition that was set out in the long-term plan. And that long-term plan looked at starting well, aging well, better outcomes for cancer, cardiovascular, learning disabilities, personalised care, and all that. And then with a greater emphasis as the time has gone on for a reduction in health inequalities. Now, if that ambition remains there and at the core of why we're having this legislation, then the issue around supporting social enterprise and the role of voluntary organisations is absolutely crucial. And it actually takes quite a big mindset shift for people who work within, particularly the NHS, who value a particular type of evidence that's presented in a particular type of way and belittle other types of evidence. So you need to really value and the knowledge and expertise that sits in very small support organisations, community organisations who really know the people at a very local level and have some great solutions. You need to invest in them, because they will not grow organically without investment. Money has to be transferred, money and skills need to be transferred to these organisations for them to do the job. I've seen too often when it comes to health commissioning that there's an assumption that these groups will just exist. They will just be there, that the lunch club will be there, the dementia club will be there, but they need investing in. And if you bring them more into the heart of your evidence base, then that would make a lot of sense. You've also, I think there has to be a real understanding of the nature of these organisations. Now, government departments and NHS organisations are frustrated at the number of voluntary organisations. HealthWatch, which is the statutory body, we have 151. They keep on asking us, could we have less? No, we can't have less. deal with the complexities. So there is something about you just have to deal with the complexities. These organisations have grown up to meet a particular need. So you will have Age UK, you will have a learning disabilities organisation and an autism one. And no, they can't merge. They bring something quite unique. And I think that the task is to learn to work with them. So the real thing around all this for me is that you have to define your vision, and I think, having listened to a lot of the work that's happened in Greater Manchester, that sort of life course vision is there, and it's about, you know, improving school readiness, improving life expectancy. If you're very clear about your vision, then how you involve voluntary organisations clicks into that, because they're the ones who have real good close contact with communities that statutory bodies just simply couldn't have. Now, if I move on briefly to the issue around a stronger voice for patients and genuine co-production, my view is that the white paper is very weak on really listening to the people who use or need health and social care services. It's very lightly written at the moment, and actually it should be a very strong core piece of work that goes right the way through from the face of the bill into the guidance, and should really have some must-dos around it, rather than, yes, it would be good if you could, because we need to move beyond. Many people do this brilliantly, by the way, so it's not of the ICSs. There are, of course, many types, and some are doing this quite brilliantly and leading the way. Others think it's okay to have 2 people on a board. So I think we need to really understand what we mean about getting the voice of the people who use or need those services into the heart of it. In order to do that, you have to build an infrastructure. It has to be funded. It won't happen organically. And you have to build trust and really prove that you're listening, which means you need a feedback loop that shows you that change has happened. You need to really work very, very hard, and through organisations like HealthWatch and many others, to get to the groups where their views are very, very rarely held. You will not hear from the Gypsy and Traveller group if you hold a consultation at 7 o'clock in the evening in a lecture theatre in your hospital. It really is about getting out, getting into communities, and really understanding what is important to them. So we've also got quite a lot of evidence that some things like peer support really work, and we don't do enough of it, and we think it's somebody else's job. But I think getting that peer support really embedded into the role of ICS is getting it in, you know, getting it really understood, that the difference that it can make, and building on that. Now, one of the things that as the leader of HealthWatch, one of our difficulties about patient voice is that we were set up out of the 2012 changes in health structures, and we were set up at that point to deliver insight to at a very local level, and a geographically local authority level, and at a national level. And we do that, and I think we do that really robustly. What we need now is that infrastructure in the middle to support ICSs, so that we can make sure that we're absolutely getting the views of the public, service users and patients into the heart of that decision making. So there's just very quickly then, so what are the changes I think that we need to see in the bill? Definitely we need a strengthening of the patient public service user voice in the bill. It must be a must do for ICSs. I have concerns about the relationship between the ICS board and the partnership board. And again, where things go well, I can see they'll work very well together and they'll share information. Where they don't go well, you can see that the partnership board could become a talking shop where the decisions are made by a smaller, tighter, NHS-led ICS board that takes the legal responsibility. So we would like to see, if they're not taking the evidence from the partnership board, they explain why, and that they do that publicly. We also think that there should be a published comprehensive guide for how they are going to, ICSs are going to engage with their local communities, and that should be regularly published and reviewed. And as I've said before,
Imelda, we're tight on time. Can you draw your remarks to a close if that's possible?
Yeah, my very last comment, and it's exactly the same as James, which is if we don't have social care reform, if we don't have a long-term plan with proper investment, this cannot work. So that's not part of the bill, I know, but it's a crucial thing that we must do. Thank you.
A vital point on which to end that session. Thank you so much, Imelda, and thanks also, James. So can I have contributions, please, from commissioners? I see Andrew with his hand up. If you want to ask a question, put your virtual hand up if you can, but I'll ask Andrew to speak first. Andrew, you.
Norman, thanks very much. Imelda, thank you very much for your support for the social and voluntary sector. As somebody who's got a very long track record in the statutory NHS, I absolutely share your concerns. And it has been said that this white paper is for the 95%. That is the 95% of activity that is statutory commissioned services. I suppose I have two questions for you, really. How optimistic are you that the mindset change that you advocate is really going to happen? And depending on your level of optimism, do we legislate or do we look for those local ICS leaders to do the right thing that operate in the best interests for patients and the people that we serve? I think I kind of know where I am, but I'd love to hear your views on that, your optimism and, you know, the, if you like, the enforcement or just getting the culture right. Thank you.
Okay.
So, Imelda, over to you.
Yeah, okay. So Andrew, optimism, very optimistic in parts. It's a bit of a curate's egg, isn't it? And very pessimistic in other parts. It depends on the leadership. It depends on a real understanding of the value that can come from working with your communities. And do we need to legislate? What I'd say is you can't really legislate for good engagement with your communities, but you can legislate for making sure that they make that public and that there is evidence that they are listening to their health and care partnership board. So they're the two that I would strengthen to make it that you've got something to scrutinise.
Thank you very much.
You're on mute, Norman.
Apologies, thank you. I'm going to bring in two people now and then get Imelda and James to respond. So first of all, big welcome to Rob Webster. It's a long time since I last spoke to you, Rob, so welcome and let's have your question.
Yeah, thanks, Norman. It's good to see you too. Apologies to the other commissioners. I've only been able to join for Imelda and James's sessions. I missed the first part of the meeting. So I'll probably start by saying I'm constantly reminded that STPs and ICSs have been policy for 5 years. So this isn't a new thing that we are doing here. And I would argue that what's happening is the legislation is catching up with the reality of how we're working. So in good systems, I think, and I would count West Yorkshire and Harrogate as a good system. Sorry, I should have introduced myself. It's because not everybody knows me. I'm Rob Webster. I'm the lead chief executive for the West Yorkshire and Harrogate Health and Care Partnership, which is an ICS. And I'm also a trust chief executive. So I think that we have been going at this for 5 years, and ICSs are different sizes and shapes and maturity. And I guess Imelda pointed to the fact that some people do this well and some people don't, and that you can't legislate for collaboration, you can't legislate for engagement necessarily. You can legislate for social care reform, which I would argue is essential, and for improved financing of local government, which is also essential. because housing, education, the environment and the economy are all part of what will make people healthy. So I guess my question is, how do we ensure that people focus on the what we're intending to do, which is to improve outcomes, tackle health inequalities, unwarranted care and variations in care and money, and don't obsess about legislation and structure, which is pathological in our makeup.
That's a fair point. Thank you, Rob. And can I bring in Paulette as well, and then we'll get responses.
Right. Can I just ask the two last speakers? The first one, James. James, you made a really excellent point around health and wellbeing boards. So could I ask you to just expand a little bit and say, where do you feel health and wellbeing boards, where do you feel it will fit in and add the most value when it comes to the care, the new health and care boards that are coming into existence? Because I absolutely get what you're saying about the value and the structures, but where do you think it will add the most value? Because people are very confused as to where health and wellbeing boards will be. So it'll be just interesting to see what you've got to say in that area, because I chair a health and wellbeing board, and I just don't want us to feel as if we're duplicating in that area. That's my first point. And my second point is to Imelda. Absolutely brilliant presentation, but I'm going to ask you a little bit about co-production. You talked about patients, and I worry you, I don't like the term patients a great deal. I prefer citizens. I'm not keen on the word patient. So the question I would like to ask you is, how do you talk really well about bringing in that patient voice, and I know HealthWatch are absolutely brilliant at doing this, and at the moment that's an area you've absolutely highlighted which is really lacking in the white paper that's out, and you've talked about how you would bring in other strong groups. But what I think I'm asking you is, how do you feel citizens could truly feel that they are being involved at that place-based level? Because we talk about them, you've said that they need to be involved, but could you just add a little bit more for me? Does that make sense, Chair?
It makes perfect sense, Paulette. Thank you very much indeed.
And I'll shut up. Thank you.
Before I bring in James and Imelda, if any other commissioner wants to ask a final question after we've heard from the witnesses, then shove your hand up now. If you don't, then we'll move on to Bill McCarthy for the final session. So over to you, James, first of all.
Well, thank you very much. And thanks for the questions, Paulette and Rob. I wanted to make a comment about what Rob has said, actually, Rob Webster, that in a sense, we are legislating for a culture change, because this should give greater surety to the kind of collaborations that have been going on that are quite risky, because when performance goes down the pan, or when financial constraint arrives, then suddenly we withdraw back from some of these collaborative approaches. And I think this will help us not do that in the main, although and I think appointing things like system level executives or non-executives, I mean, you know, would be a really good thing, so that people don't think organisation, they do think system. It seems to me that's really important part of the change. Although there are some, you know, just remember we have a green paper on procurement, which is sending social care in the other direction, which is abolishing the light touch regime for the social care procurement. So we'll have to procure everything if that goes through as is currently planned, which is utter madness. But to come into Paulette's question about health and wellbeing boards. So obviously in some areas where there's a really good fit between a health and wellbeing board and a health and care partnership, they should just be the same, it seems to me. But in other areas where health and wellbeing boards might be nesting in a larger ICS, then you've got a different configuration. So I think the health and wellbeing board can serve as a partnership. It seems to me to be an opening question in every case. But secondly, health and wellbeing boards are a way of overseeing integration strategies or prevention strategies in particular. And I'd make a plug for a small and much maligned fund called the Better Care Fund, which Norman might well have a bit of history with that, actually. But
I do.
Which is not sycophancy from a fellow Norwicher, but actually those funds have been the one area where we've been able to pull risk, actually. And it seems to me if we're going to expand integration, we have to have mechanisms for putting money on the table in ICSs, in either the NHS body or the partnership. And seems to me health and wellbeing boards are a really good way of overseeing prevention approaches or places where you can explain change to the public, because of course not everything we do in an ICS is going to be popular. Actually, if we're trying to if we're addressing inequalities in my area in Great Yarmouth, where life expectancy has gone down, it's going to need the people of North Norfolk to understand that resources have got to shift that way, and therefore health and wellbeing boards are quite good at, it seems to me, at explaining that change and containing some of the politics. So I think they're crucial.
Thank you, James. Imelda?
Rob's point about how do we keep focused on the outcome and stop obsessing about structures is a good one. I think we're just going to have to obsess about it for a little while whilst the bill goes through, because if you don't get your framework right, it could take us the wrong direction. But I completely agree. This is about improving outcomes for our population. It's about reducing health inequalities, and certainly no one should take their eye off that ball whilst they focus on getting the legislative structures in place. Now, Paulette's issue. Do you know what, Paulette? I hate patient too. I only use it because people in the NHS won't know what I'm talking about. They won't think I'm talking about their people if I don't use it. It doesn't come naturally to me because I think about citizens, about people. You will always find me saying a very long sentence, which is the public, patients and service users, so that I'm describing who I mean, and then people can understand it. But the NHS just does say patients, so I need to know that I'm talking about the people that come through their services. And the issue about how do we get that real involvement? Now, I think what we need to do is really allow organisations to build partnerships and to build trust and to transfer some resources, because you're not going to hear from people unless you go to where they are. If you ask people to come to you, you'll get the same types of people who'll come. There'll be this, if it's a hospital, it'll be the people who are likely to be your governors. And that's great. They do a really great job. But if you want to get to the people who are not using your services, who are further away, you have to go there and you have to spend time and you have to transfer some resources and you have to really get to understand. We did a piece of work on people accessing services, and one of the major issues across the whole country was transport. It was about, and so we're about to build or refurbish 40 new hospitals. Please look at transport. Please go, if you're in Essex, please go to the people of Jaywick, sit with them, spend time there, work out where they will travel to and where they won't and why they won't, and build services around it. But it is labour intensive, and it means letting go of some control and power, and that's never easy because you're also accountable for it.
Thank you so much, Imelda, and thank you also, James. We're out of time for your session now, I'm afraid, but it's been brilliant having you both with us, and very valuable to hear your evidence and your responses to questions. It's a great pleasure now to bring in Bill McCarthy, who's the Northwest Director at NHS EI. And Bill, it would be great to hear from you sort of in response to what you've heard this afternoon from the witnesses and from the commissioners and their questions to witnesses. So over to you for another sort of 7.5 minutes, if that's possible.
Thank you very much, Norman, and thanks for the invitation to contribute. Clearly, I can't talk on behalf of DHSC or government on the white paper, but we're really happy to give a perspective from NHS England, but perhaps influenced quite a lot by my location in the Northwest, and certainly very much of what Michael Marmot was saying at the start absolutely rings true in the Northwest in our experience of COVID over the last 12 months, which, as I think Mike would agree, isn't just about how COVID has impacted people, but it's about how it's revealed some of the deep and enduring inequalities, which the Northwest certainly has more than its fair share of. So I should go back a little bit, back to November, where we set out in a paper then our broad view of the next steps for ICSs. What are they for? What's the purpose of them? And how do we see that then flowing through? And certainly that's been then it's been influenced. It's moved through the consultation process, and the government's department taking receipt of that in the white paper. But I guess that November paper is still my starting point of what we're trying to achieve. And we set out there 4 purposes for integrated care systems. One about outcomes, about health outcomes, but outcomes of care as well. Secondly, inequality, and it is health inequalities, inequality of outcomes, but it is also about inequality of access to all of our services. Thirdly, and I expect increasingly important, will be productivity. We will be tested collectively on our ability to make the public pound go as far as it can. And fourthly, in reflecting, I think, a fair bit of the conversation so far, and something which perhaps isn't quite as prominent in the white paper, was this commitment to the NHS stepping up in its contribution to wider social and economic development. And we don't see those 4 as trade-offs, we see them all as essentials, and they should be built in to the way we develop and support the building of integrated care systems across the country. We have 3 then sort of principles we draw from that. So if that's what we're about, what do we think that means for the way we frame the future of services? And I think the first of those is, we believe decisions made closer to the communities they affect are more likely to give better outcomes in those 4 areas. Secondly, we think we are signalling an important shift towards collaboration. So seeing collaboration as the driver, which is more likely again to achieve those outcomes than competitive behaviours. And that's collaboration across the NHS, but also really importantly, collaboration in its broader sense with local authorities, not just social care. Housing has been mentioned as really important, with the voluntary sector, with others in our communities. And the third principle, I guess, was around appropriateness of level, and within that, the importance of place. We think places where we can best together understand our communities, the priorities for those communities, and who's at risk of getting left out in communities, and put a simpler, more coordinated response together. The third point on the purposes, the principles I just want to raise is what we see as the importance of permissiveness in the way that we roll out and develop integrated care. I just want to dwell on that for a moment. It can be, I think, interpreted by some as a kind of it's a free-for-all, and anything goes. It's whatever you fancy, wherever you are, and that's not why we think permissiveness is important. I think it's a much more rational recognition of difference around the country. So we know geographies vary significantly, and therefore the way that we collaborate, the way we organise ourselves should be different. We know population health and population health priorities will be different between urban areas, rural areas, poorer areas, more prosperous. We know the scale of integrated care systems is different, ranging from about 500,000 to nearly 3 million. So the way they will relate to communities will necessarily be different. How load bearing they are for different functions will be different. And of course, I think Rob mentioned this, the maturity and the strength of joint working is different, because some areas, Greater Manchester, I think of in my patch, started on this journey before others. So permissiveness isn't anything goes, it's the way we see to connect real local circumstance to the outcomes we're trying to achieve. And in the way then we develop and support systems, we'll be putting in a test, why are you wanting to organise in this way? And we'll be looking to see that that's legitimised, if you like, because that's how we'll best relate to partners. That's how we'll work with communities. That's the set of arrangements which will have the best impact on health outcomes, tackling inequalities, enhancing productivity, and really contributing to social economic development. So I think, Norman, I'll stop there, I guess, just with one plea then, which is the consequence, I guess, for that analysis of why we think permissiveness is important for the way legislation is then framed. We think there should be, really clear ambitions of the sort we've talked about, but our ask, I guess, is that we resist the legislation trying to do too much, trying to prescribe too much, trying to get into too much detail, which in the end, I think, could risk getting in the way of local partners working most effectively for the people they serve.
Thanks very much indeed, Bill. That was brilliant, and appreciate your discipline on time as well. So I've got Alistair's hand up. If any other commissioners want to contribute in asking questions, please show your hand. I've got Andrew's real hand up. Anybody else wanting to show their virtual hand, they'd be welcome to do so. But Alistair first and then Andrew. And I'll call 2 or 3 and then get Bill to respond. So Alistair first.
Thanks, and thanks very much, Bill. And in speaking, you helped answer one of the questions I asked right at the beginning about how didactic legislation needed to be and how much space we have to give for creative attention, and you answered that well. If that's the case, I remember when I was in post, finding it very difficult to get examples of best practice around the system as well as we should. It's never been easier to communicate best practice, but it wasn't always possible, and it was a bit frustrating. Are you already seeing in the nascent ICSs examples of really good practice, and accordingly, are we building up, even at this early stage, some examples of that? So if we're not going to lay down in legislation what everybody should be doing at every second of the day and in every circumstance, as we don't want to, we're already building up the examples that we can point people towards in order to help the smooth transition of the system and assist people moving towards the very best. Thanks ever so much.
And I wonder whether he's going to mention West Yorkshire and Harrogate. But first, let me bring in Andrew and then Rob Webster.
As long as he mentions Berry, that's all I care about.
And I've got Phil as well. So Andrew first.
Thank you very much, Bill. Hi. I suppose it's a quick question, really. You're an extremely experienced NHS leader, and as you know, many years ago, I was not too far from your part of the world in Yorkshire, a system that I understand, and more recently, I've operated in Birmingham. I suppose for me, and we've sort of often said this for those of us who are now outside of the statutory NHS, how do you think these proposals will not go back to, if you like, a cultural default of what's been termed a cosy cabal of NHS statutory providers? How will this time statutory NHS providers behave differently? And whilst I do acknowledge the thesis, if you like, that we shouldn't legislate for that, how actually will the system assure itself, and how will the regulatory system, how will the voice of service users feature to ensure that these new ICSs are really representative of the communities they serve, and it doesn't default into the cosy cabal of statutory providers? That's my question.
An important concern, Andrew, thank you. So next, Rob.
Yeah, thanks. I always look to Berry for my inspiration. That's for sure. I'd love to be able to talk to Andrew about cosy cabals and whether they're real or not, and that people are actually changing their behaviours. But the question I had for Bill really was about, first I'm going to welcome the fact that things are permissive and that there's no plans to legislate for what happens at place. I think that's really important. But where, Bill, do you think that the legislation does need to be tight, and where is it essential that it needs to stay loose?
That's an interesting challenge for Bill to think about. But before you respond, Bill, let me just bring in Phil.
Yes, thanks very much, Norman. I wasn't going to say anything, but I'm just intrigued about the difference, or Bill's perceptions of the difference between the NHS paper that came out in November and the white paper, and what's been gained or lost. The impression I've got, and I don't know whether this is true, is that the NHS paper was broader in scope, had a wider sense of the purpose of ICSs, and embraced a bigger agenda around population health improvement, mentioning health inequalities and so on, which felt to me as though we'd lost something in the white paper that then came out. And I suppose there's always as I know from my own experience, the tussle between the department and the NHS, but just wondering whether or not what it is we may have lost, and therefore we as a commission and others might want to see put back in from the original vision of the NHS.
Over to you, Bill.
Thank you. So I'll take them in turn. Alistair's point on best practice is spot on. For those of us who've been around a long time, we know this is a sort of a continuing frustration at times. There is still a bit of a not invented here culture in some parts of not just NHS, but I think public services. We are already collecting, and it's the real examples, isn't it? It's not so much the interesting governance arrangement, it's the real examples of change. And I was thinking earlier when Michael was raising the issues of the sort of the broader contribution, which, as you say, wasn't quite as prominent in the white paper, and I will pick up on Phil's point at the end. But two current examples sprang to mind, which will be part of the sort of compendium that we're working on. The new hospital bill that's been announced for North Manchester. I mean, the way that project has been developed is absolutely seeing how not just the product that's produced can be a much broader asset for the communities there, who are some of the most disadvantaged in the Northwest. But the process of the building, and how are we training, how are we bringing in local people to make a difference? We can really set out some practical examples of how the NHS can contribute. I'm also struck by, I will pick a West Yorkshire one, just to make sure that Rob still talks to me afterwards. There's some fabulous work in Bradford where between the council and the NHS, a real concern for young people with learning disability. They're not just their health prospects, but their life chances, and indeed bringing in businesses in the city. We made a commitment that all young people with learning disability leaving special schools in the city would be offered a year's support, training, like a kind of apprenticeship between the employers. Biggest one at NHS, but that would lead to a kind of a casual, if you like, recognition of what they learned over that period. And it led to 70% continuing employment for those young people, which benchmarks extraordinarily well. There are some real practical things that we can do through that, collaboration at place with the broadest outlook. So I think Alistair makes a cracking point, which we are on, but I think we could do better on, if I'm honest with you. I'm not sure I'd recognise all the cosy cabals, but no doubt Andrew can send me a note afterwards. I do think transparency is going to continue to be really important. I distrust business that's done out of sight of the public, and not just kind of full business, but the way we go about making decisions. It goes to the points I've made earlier about not just trying to think, well, what do these people need, but involving communities in, defining their aspirations and then designing the right responses and the right support. I think that will play out particularly at place, and that's, I know it's a slightly vague phrase, and that's because of the difference in scale. Down in Dorset, place and the ICS might well be pretty much the same thing for Robs and for in North West, we've got very large ICSs. It is a place at borough level, really working with those known, understood advocates for communities, with the voluntary sector there. I think that's where that engagement, that transparency of decision will really play out. And that does mean that in the way we develop and guide the development of ICSs, we will be expecting decisions in the big ICSs to be pushed down into the place arrangements, and those place arrangements to be described and to be open. Again, not saying for legislation because of those differences, but certainly something we in NHS England can keep a wary eye on. Rob, in legislation, I think keeping tight on purpose. What's this all about? Looking at the duties that from CCGs or transferred. Does that really hit the aspirations? Around the outcomes, tackling inequalities in the way we're seeking to achieve. And I think that that for me is almost the core of it, because then we draw. The testing of the arrangements that are coming out, the outcome measures we want to see, that's rooted in that purpose, and that's why whenever I'm talking about this, I try and go back to those four. Whether I'm chatting to my systems or whether I'm working in this kind of environment. Phil, what a very good question. I think you're exactly right. I think the white paper is narrower. I expect it's narrow because its intent was a bit narrow. It's setting up the legislation. So that doesn't really disturb me particularly. It was, it's there for a particular purpose. I think the assurance I want to give you is that in NHS England Improvement, we think we have a broader responsibility, which absolutely is for implementing the legislation when it goes through. But I don't see us confining ourselves to that. It is about making sure that the broader aims, the great practice that's already there and evident, that's known, it's visible, it's public, and that people feel supported, not just in kind of turning into a bit of an insular debate about who's sitting on what committee at what level, but really is purposing the change in order to achieve those outcomes, tackle those inequalities, enhance productivity so we do more for more people, as well as contributing, as we should do, to the broader good and well-being of the economy and society locally. And that's what we will see as our remit. Part of that, an important part, implementing legislation, but I think the broader aspirations you have seen in the November piece, we still hold dear.
Thank you.
Bill, thank you so much. And I'm afraid we are out of time, but this, I think, has been a really rich evidence session. Can I thank particularly the 5 witnesses who've given evidence this afternoon? They've all been outstanding. Can I thank the commissioners for your reflections and your questions? Can I thank the Secretariat for planning the whole thing? There's a lot of work goes into this. We've had 64 people, I just noted, tuned into this afternoon. But I also want to bring in Phil from the Secretariat to say a few words as well. Phil.
Oh, that's fine. Well, thanks very much, Norman. Thank you for chairing so well. And can I echo your contributions? It does seem to be that point that was being made right at the end by Bill, that if we are to respond to Michael Marmot's challenge about tackling the social determinants of ill health, rather than just making a better health service, then the purpose of ICSs, which was the focus of today, is absolutely critical. And I certainly want to see that written in as a tight bit of the legislation. Let's be very clear about the purpose. Form follows function. We can argue about who's on what boards later, but unless you've got the purpose of trying to improve the population's health and tackling health inequalities, I doubt people will do it. So I think that's really, really important. I also think that the leadership and the trust, the relationships that people have talked about is absolutely vital. This isn't just about lobbying upwards, it's about lobbying sideways, if I can put it that way, to get the whole system to shift in this direction. The normal curve of ICSs, we want everybody to be the broadest scope and the best relationships and the trust at every level. So that's really important. And I think this idea that the ICSs not only have to deal with health in all policies, whether it's housing, the economic development and so on, I like the idea that we should be thinking about economic and well-being in all health policies, the sort of reverse of that. And if we can arrive at that place, and if ICSs was delivering that, then I think we stand a chance. Lots of issues about funding, I get that. Public health came up, funding for the voluntary community sector, funding inequalities for different parts of the country. I guess that is the big picture question, which we haven't addressed today really, Norman, but it sits underneath everything. And without the resources, particularly on social care, and as a former social care minister, obviously I'm extraordinarily keen to see that transformation happen. We do only have a glass half full. We have to deal with the other half of this health and social care system. And the bits of social care assurance and things that are in the white paper, fine, but they tell only half the story. So this is fantastic, the evidence we've got here, and people on the chat have made some fantastic.
Yeah, I agree.
Say that we will draw on all of those contributions, and if people after today are thinking, there's something else we should draw commissioners' attention to, please send it to us, because then we'll draw on that when we produce the final report.
Thanks. So we want to keep the Secretariat busy.
Thank you for that. Yes.
And Steve, do you want to say a very quick word about the next session?
Yeah, thanks, Norman, and echo all that, and thanks to you. Yeah, very quickly, on the 21st of May, 2 till 3:30, we've got the follow-up session that will be looking at, maybe we'll be obsessing at least for an hour and a half about structures and power. We've got Lord Victor Abadwali confirmed as a speaker who fortunately wears 2 hats, NHS Confed Chair and Social Enterprise UK, so that's very helpful. Councillor Ian Hudspeth, who is the chair of the LGA Wellbeing Committee. So he will be very important in terms of the LGA's view about getting these governance structures right. And also we've got Jackie McKinley, who is from the Centre for Governance and Security. And we are in discussion with Edward Agar's office. He is the Minister of State for Transformation, and we're very much hoping that he will also grace us with his presence and hear the debate and contribute. So yeah, that's all there. So please register via the website. It's all there on the front page of the website. So please do. It'll be a good session, and Andy Burnham's chairing that one.
Thank you, Steve. And before we finish, I should also give a shout out to all our partners who make all of this possible. So NHS Confederation, Local Government Association, London Councils, Social Enterprise UK, Northern Health Science Alliance, British Association of Counselling and Psychotherapy, and also the Greater Manchester Health and Social Care Partnership, and the West Yorkshire and Harrogate ICS. So thank you all very much for partnering us on this venture. And thanks again to the outstanding witnesses we've had this afternoon. It's been a rich discussion and will inform the short report that we produce as a result of it. So thank you all very much indeed. Go out and enjoy the sunshine if you're as lucky as we are in Norfolk. So thanks a lot, all of you, and good afternoon.
Yes, thanks, Norman.
Bye-bye.
Bye.